Good afternoon. My name is Jim Twell, and it is my honor indeed to introduce my friend and colleague, Joseph A. Durrani, president of the Congenital Heart Surgeons Society. Joe is the first child of Dr. Abraham and Elizabeth Durrani of Norwalk, Connecticut. His parents went on to have 8 more children, all girls. Here's Joe pictured with his 8 sisters and his mother, Elizabeth. Joe had a happy childhood in Norwalk, Connecticut, with the possible exception of having to wear formal wear. He completed his undergraduate education at Fordham University in the Bronx, and then earned his medical degree from Georgetown University School of Medicine in Washington, D.C. Dr. Durrani's inspiration to pursue a career in medicine was largely driven by his father, an old-school, genuine family physician who often treated his patients by making house calls. However, the decision to pursue a career in cardiothoracic surgery waited until the end of medical school. Then he had the opportunity to rotate in the service of Dr. Robert Bruce Wallace, past president of the ATS, and it was then he decided that he wanted to be a cardiothoracic surgeon. Dr. Durrani did his general surgery residency at Georgetown University Medical Center. During his residency, he spent 2 years as a research fellow at the Brigham and Women's Hospital and Harvard Medical School. He completed his thoracic surgery training at the Mayo Clinic, and then completed a fellowship in congenital heart surgery and transplantation at Loma Linda University under the direction of Leonard Bailey. He returned to the Mayo Clinic to join the staff in 1997 and has remained there throughout his career. There he had the opportunity to work with giants in our field, including Dr. Puga and Dr. Danielson. He was ultimately promoted to the chair of the Department of Cardiovascular Surgery and now holds the Sheikh Zayed Chair of Cardiovascular Diseases. It is certainly challenging in 5 minutes to summarize a career as accomplished as Dr. Durrani's. We all know him as a giant in pediatric and adult congenital heart surgery. He is a world leader in the care of Epstein's anomaly and hypertrophic cardiomyopathy. He has a diverse research portfolio, including innovative valve repair techniques, heart failure therapy, and stem cell therapy. He has over 550 peer-reviewed publications and has given countless lectures. And he's not just the president of the Congenital Heart Surgeons Society, but also the Society of Thoracic Surgeons, and will be the next chair of the American Board of Thoracic Surgery. Quite a list of accomplishments. Dr. Durrani has been deeply involved with humanitarian outreach activities in Asia and South America and has made more than 20 trips to those countries over the past 2 decades. In addition, he served as medical director of his favorite charity, the Children's Heart Link, for over 20 years. Dr. Durrani and his wife, Anne, who is a nurse, have been married for over 28 years and have 3 children, Michael, 26, Grace, 23, and Patrick, 21. Joe explains that he and Anne tell their children the same thing that he tells young surgeons. Find your purpose and passion in life. Do what you love to do, and you will be great at it. There is always room at the top. Joe loves spending time with Anne and the children. He enjoys cars. He loves shoes. He collects pins and prosthetic heart valves. He loves to play golf. We've played golf together, and we've actually had the opportunity to play music together in the Baby Blues Sound Consortium. Our most recent performance was in Washington, D.C. at Blues Alley in February of this year, before we learned about Zoom meetings and COVID. Indeed, Joe has led the response to COVID, the COVID epidemic in our specialty. He has spearheaded multiple publications that provide guidance for the care of our patients, safe resumption of surgery, and residency training during the pandemic. During this time, he has led not just our society, but also the Society of Thoracic Surgeons, and has navigated the tasks vital to our professional societies, how to hold meetings and fulfill the essential missions, including the exchange of ideas and advancing our specialty. Really has risen to the challenge of these very challenging times. So, ladies and gentlemen, please join me in welcoming Joseph A. Durrani, President of the Congenital Heart Surgeons Society.
What is it that makes the contributions of an organization so special, so impactful? Greatness comes not only from the special skills and intelligence of the Society's membership, but also from preparation and timing. In the words of Dr. James Kirkland, it is the intersection of the timing of a unique opportunity with the vision, skill, and preparation of the individuals involved that translates into a unique contribution. For the intentions of this address, Purposeful Legacy Building will focus on the challenges that face our specialty today and the opportunities for CHSS to contribute by seeking and finding innovative solutions to confront the problems at hand. By effectively confronting the challenges of today, we will build a legacy for tackling the issues of tomorrow. In the earliest era of congenital heart surgery, progress and legacy was defined mostly by, quote, new operations. Today, I believe our opportunities focus more on innovations in processes. Process innovations can be defined as novel methods to improve outcomes, maximize efficiency, or decrease cost. Challenges facing our specialty today include 1. Strategies for using big data for quality improvement initiatives in a culture of public reporting and competition between institutions. 2. Maintaining fiscal responsibility in one of the costliest specialties. And 3. Increasing our advocacy initiatives to secure sufficient resources to achieve success with the challenges I've just highlighted. CHSS is now the face of congenital heart surgery in North America and has the respect of both our peer organizations and the public. The time is right for CHSS to address the challenging issues and make impactful contributions at this critical time in healthcare. This is purposeful legacy building, and this is how CHSS can do it. The United States healthcare system is a complex collection of systems, with each domain functioning as a system in its own right. The conundrum with this systematic view of the United States healthcare is the obstacles that exist between these domains, which limit their communication and interaction. Reconfiguring these interfaces is beyond the scope of this presentation, but suffice it to say, a successful reconfiguration would inevitably assign a critical role to the healthcare providers since we sit at the nexus of all of the domains. As surgeon providers, we will focus on a few key areas within this complex system as it relates to congenital heart surgery and identify opportunities where we can proactively make a difference and contribute to what I believe would be CHSS purposeful legacy building. Fortunately, quality assessment and improvement and clinical research in congenital heart surgery have been key areas of emphasis since the earliest era of CHSS, when Dr. John Kirkland recognized that small anecdotal experiences presented at informal meetings would not satisfy scientific scrutiny, and so he began the CHSS Data Center in 1984. The home of multi-institutional prospective inception cohort studies using advanced statistical methods. Drs. Kirkland and Eugene Blackstone, a talented biostatistician, focused these studies on patient outcomes and not simply procedural outcomes. This multi-center clinical research strategy was unique since it was defined by an inception cohort of patients with a diagnosis at entry, and outcomes were defined by strategies of patient management as opposed to specific operations. Consequently, analyses included patients that died without surgery, and lifelong longitudinal follow-up of enrolled patients was the overarching plan. Numerous CHSS patient cohort studies over the last 35 years have resulted in presentations in our most prominent societal meetings and hundreds of peer-reviewed publications in our most prestigious journals. A research legacy that started decades ago and continues today, now with the esteemed Kirkland Ashburn postgraduate 2-year fellowship position. In parallel to the inception cohort studies being done by CHSS, the STS National Congenital Heart Surgery Database emerged in the early 1990s as an effective and widely available platform and tool for quality assessment and improvement for surgeons and their programs. For 3 decades, centers performing cardiothoracic surgery have utilized the STS database for clinical data analysis and feedback to provide a platform for center-level quality assessment while also benchmarking national-level aggregated outcomes. The STS database is focused mostly on, quote, quality assessment, as opposed to the CHSS data center that has functioned primarily as a clinical research tool, examining long-term outcomes. But both stratagems are designed to ultimately improve quality of patient care. Strengths of the STS database include, one, the use of standardized international nomenclature that is being incorporated into ICD and will also be used in administrative and claims databases. 95% penetration that provides a truly representative national benchmark, and annual program audits that have demonstrated high data entry accuracy and completeness. The National Quality Forum has also endorsed STS's stat mortality categories as a national voluntary consensus standard suitable for public reporting and quality improvement. The STS database's expanded measurement portfolio now includes mortality risk models, incorporating procedure by age group pairings, as well as individual patient factors of age, weight, prematurity, chromosomal and syndromic abnormalities, and non-cardiac anatomic abnormalities, comorbidities, and preoperative factors such as mechanical circulatory support. These comprehensive data sets and advanced analytics have been validated with a remarkably high C statistic of 0.86. The next evolutionary phase of the database will provide a broader perspective on quality by incorporating a composite measure that includes mortality, morbidity, and length of stay. To explore the potential added value of including diagnosis procedure combinations rather than procedures alone as the basis for STS risk models and performance assessment, and to investigate whether new artificial intelligence and machine learning approaches offer advantages over traditional logistic regression, Dr. John Mayer and a group of distinguished CHSS and STS congenital colleagues have collaborated for more than a year with Professor Sharon Leese Norman at Harvard, who is one of the main statistical editors for the New England Journal of Medicine. Results of this study show that overall, the performance of the current STS congenital risk model is at least equal to that of all the alternative approaches that were explored. The one exception was that STS models tended to somewhat overpredict mortality, most notably for the highest risk procedures, which does not provide added protection for centers performing such procedures. None of the new models tested produced consistently good results for some of the most challenging, often uncommon risk prediction scenarios. Despite the very reassuring finding that the existing STS risk models perform as well as the most advanced, state-of-the-art statistical approaches in the 21st century analytic toolset, we are not resting on our laurels. Continued refinement of the current analytical models is underway with input from CHSS representatives. New empirically derived stat categories have been developed, and a portfolio of benchmark procedures with their associated performance metrics is being explored, which some believe would be the most helpful to the patient and public communities. Other significant advancements are also in progress, including longitudinal outcomes such as reinterventions and functional health status that are currently available only through long-term CHSS cohort studies, acknowledging that at the present time, these are limited to patients with specific diagnoses managed at selected centers. Integration of the National Death Index data into the STS database will also facilitate documentation of long-term survival. Patient-level socioeconomic indicators will be incorporated, and this will facilitate our understanding of associations of these factors with outcomes, potentially disparities in care, and opportunities for improvement. Finally, the STS Artificial Intelligence and Machine Learning Working Group that includes CHSS representation will continue to explore how these new analytic approaches may be useful for very specific, particularly challenging applications in congenital heart surgery. All of these quality assessment and improvements and enhancing clinical research represent society collaborations and legacy-building opportunities for CHSS. Let's switch gears and address a controversial topic of significance: public reporting. Despite documented validity of STS data acquisition and analysis, some surgeons have been disgruntled with public reporting methods due to concerns that characterizing center-level performance with a star rating system oversimplifies a complex phenomena. The STS reached out to the CHSS for guidance on this controversial issue. Results from a CHSS survey regarding these concerns led to a decision to defer the use of star ratings in congenital public reporting. However, it is important to acknowledge that these ratings were statistically completely appropriate and that the 1- and 3-star designations were synonymous with and statistically identical to, quote, worse than or better than expected classifications used by virtually every other credible performance rating program in healthcare. The current approach is to present outcomes data and statistical inferences to stakeholders, including the public at large, with comprehensive, understandable explanations in the language of a layman. The public, on the other hand, has been dissatisfied with, quote, difficult to interpret website displays of complex data that reflect program outcomes. At the same time, many in the surgical community expressed concern that overall center-level performance was described with a single-star rating, which oversimplified a complex phenomenon. Despite these seemingly conflicting concerns, CHSS believes it is our ethical responsibility to public report in order to assess and ultimately improve care of patients, show whether program outcomes are consistent with an inference that they are safe and competent, and provide the public with program outcome metrics based on data that have been uniformly collected and analyzed using the best available risk models that are calibrated and periodically updated using contemporary aggregate data sets from all participating centers, while program-level analysis is tailored to reflect each center's unique case mix. And finally, provide patients and families with information that will be helpful to them in making important decisions about their child's care. The understanding that you are going to report your program's results is an impetus to identify and fix festering problems. For example, stimulating your hospital to invest in additional resources, new equipment, additional staff, dedicated ICU, dedicated anesthesia, etc. People from other healthcare domains will unavoidably grade us by using whatever metrics are available, irrespective of accuracy and whether it's misleading. So, it's in our best interest to ensure that the public has access to verifiable data analytics, and the current and evolving ST methodologies serve as that validated reference point. Finally, CHSS collaboration with patient advocacy groups, for example, Conquering Congenital Heart Disease, Adult Congenital Heart Association, Children's Heart Foundation, Mended Hearts, and so on, should be sensibly and sensitively handled so the medical profession understands what information is most helpful to the public. For example, reporting benchmark procedure outcomes and presentation of information in a clear and understandable way. Continued modifications of the STS website with CHSS guidance is underway, so we meet the requests and expectations of the public and the medical profession. This is yet another important legacy-building opportunity for CHSS to collaborate with STS and refine these important issues. Regionalized care has been a controversial and sensitive subject, but let's be honest with a truthful self-assessment. The literature has confirmed a somewhat complex yet indisputable real inverse relationship between case volume and outcome in pediatric heart surgery. And there are numerous congenital heart surgery programs in the United States with wide variability in practices, care delivery, and outcomes. And based upon multiple models, it has been postulated that a regionalized model of care of some sort would improve the overall quality of congenital heart surgery care in the United States. The end result would be optimally placed hospitals or programs so that each would perform approximately 300 cases per year while minimizing the travel burden for patients and families. Science has demonstrated more evidence for regionalization. And this strategy would achieve improved quality and outcomes for each individual program. One impetus for regionalization stems from the negative press in newspapers and national media that reported poor program outcomes. The theme of concerns pinpointed wide variability in care delivery models, best practices, and mortality and complication rates that exceeded national norms. Not surprisingly, most of the programs of concern were lower volume with challenges related to resources, ancillary services, and staffing models. The suggestion of a critical volume of 300 cases annually comes from multiple European studies that documented an inverse relationship between case volume and mortality that appears to be even more significant as case complexity increases. This presumption is also supported by publicly reported STS data where a median annual volume of 300 cases per year was associated with an adjusted mortality rate of less than 2% compared to a mortality rate of greater than 4% when the median annual volume of 100 cases per year. These are the bare and simple facts. One of the most powerful impacts of high volume is familiarity with the entire clinical picture. With this comes the ability to anticipate potential problems, recognize challenges early, and implement effective strategies to mitigate complications. Larger volume centers have this professional depth amongst nursing and allied health staff, where smaller centers do not. These improved outcomes at higher volume programs also reflect an infrastructure with a critical mass of other workforces, for example, anesthesia, critical care, radiology, pediatric surgery, gastroenterology, nephrology, neurology, and so on. In addition, there is also a need for readily available ancillary services, for example, the emergency room, imaging, laboratory medicine, pharmacy, etc. This comprehensive infrastructure results in an efficient hospital system that runs 24/7, 365 days a year, a model that cannot be easily reproduced and maintained in low-volume programs. Despite overwhelming evidence in favor of regionalization, there are some potential downsides. First, the resultant elimination of a fully functioning cardiovascular service line in some pediatric healthcare institutions may result in loss of some hospital-wide resources and capabilities that could potentially compromise the quality of care in other specialties. Second, cardiovascular services are also a high revenue source for the hospital and often support other underfunded specialties and areas of the hospital. And finally, additional and understandable concerns driving resistance to regionalization include job loss and institutional loss of prestige. Potential strategies to mitigate these concerns could focus on creating, quote, win-win situations between neighboring institutions. For example, maintenance of low to moderate risk procedures in a lower volume program and referral to an adjacent moderate to high risk procedure to larger volume programs. Specifically, a regionalization strategy could mean collaboration or alliance between neighboring programs and does not necessarily mean program closure. This partnership tactic is something we have done at Mayo, joining forces with Dr. Overman's program at Children's Minnesota in Minneapolis. Our two programs have complementary skill sets and joined together result in one of the most all-inclusive congenital heart surgery programs in the country. Bottom line, there is increasing evidence to support some type of a regionalized model. I believe we should be proactive and apply creative models of regionalized care. Not every legacy is without pain, but a proactive approach by the CHSS to examine and support some form of regionalization could become one of the greatest CHSS legacies. It would set a powerful example in the healthcare industry, instill confidence in our medical colleagues and the public, and most importantly, it would improve quality and outcomes. And in the long run, it would also decrease costs in this expensive, resource-intense specialty that involves complex, multidisciplinary care. Talk about legacy and impact. Clearly, one of our greatest challenges today is the cost of doing business. Diagnosis and management of congenital heart defects is one of the most expensive sectors in the healthcare industry. Since operations are required for most patients, longer hospital stays are the norm, and the specialty touches patients of all ages, from cradle to casket. Over the last 4 decades, surgical outcomes have steadily improved and are excellent, even for many high-risk lesions. Most patients are expected to have a good quality of life, be a productive member of society, and live well into the adult years. Wow. Talk about an impactful legacy that each of you can claim some degree of credit for. Yet in adulthood, repeated procedures may still be needed for residual or recurrent lesions. Congenital heart interventions span all age brackets. Reinterventions are increasingly complex. Comorbid conditions are frequent, such as hypertension or diabetes. Other organ systems become adversely affected, for example, kidney and liver, and inpatient hospital stays are longer and more expensive. We live in an era with increased emphasis on quality of care, while at the same time reducing costs. That is, high-valued care. In addition, we are also graded and increasingly reimbursed for valued care. Value-based medicine has been clearly defined: quality, which equates to outcomes plus patient experience, divided by the cost. Management of congenital heart disease is resource-intense, and the literature demonstrates substantial variation in cost of care between congenital programs in the United States. Multi-center studies confirm a correlation between higher cost and complications, resulting in prolonged hospital stay. Other multi-center studies championed by Dr. Sarah Pasquale, utilizing clinical data from the STS database and cost data from the Pediatric Health Information Systems database, also demonstrate a relationship between better outcomes and lower costs. The bottom line is, there is growing evidence that lowest cost hospitals provided the highest quality care. And this quality-cost relationship was observed across the spectrum of surgical complexity and identified lower-cost hospitals to have a shorter length of hospital stay and a trend toward fewer complications. Implications of these findings suggest that policies, care pathways, and quality improvement initiatives may also have potential for reducing costs that lead to higher valued care. This is another example of opportunities in process innovations that CHSS could champion for our specialty. Although the potential cost savings are greatest for complex operations, such as the Norwood procedure, strategies focused on lower complexity procedures that are more commonly performed would also yield significant cost savings. Simply reducing the hospital stay by 1 day for a long list of low-risk lesions, such as VSD or tetralogy of Fallot, at every hospital in the country would yield a tremendous national cost savings. Like it or not, it's time to be bold and prepare for capitated health care, which is in the foreseeable future for selected pediatric services. The importance of being proactive and directing more of our attention to cost reduction initiatives cannot be overemphasized, and this is another CHSS legacy building opportunity. Finally, I would like to shift gears to advocacy, another area of opportunity for CHSS legacy building. Now that CHSS is viewed as the leading society for congenital heart surgery in North America, it is time to collaborate, expand our presence, and influence policy making. In the world of government relations, this partnership would be with STS, since they lead the way in advocating on behalf of cardiothoracic surgery through their advocacy workforce and government affairs operations in Washington, D.C. Only a few congenital surgeons have participated with STS advocacy to date, and now's the time for more engagement. This is an all-hands-on-deck moment for cardiothoracic surgery, since major changes in reimbursement for cardiothoracic surgery start in January of 2021. Although payment cuts are focused on the Medicare population and do not presently affect our practice to a significant degree, it is critical since Medicare policy changes are a forecast for Medicaid policy changes, and this arm of CMS does affect our practice. Planned CMS Policy changes beginning 2021 include up to a 9% reduction in Medicare reimbursement payments for cardiac surgery. And to be specific, the evaluation and management impact is also added into Medicare cuts. The combined cuts for cardiothoracic surgery will be up to 13% for cardiac surgery and 12% for thoracic surgery. Unfortunately, these cuts are coming at an inopportune time when our healthcare system is already strained due to the COVID-19 pandemic that has resulted in patient access issues, especially for the surgical specialties. The impact of COVID-19 causing elective surgery cancellation or delay has resulted in faculty salary reductions, elimination of FTEs, closures of private practice, and deferral of new technology purchases or other hospital infrastructure improvement initiatives. During a recent STS webinar, surgeons were surveyed to learn how they might respond to the anticipated Medicare cuts. 35% were considering early retirement. 35% may be forced to limit care to Medicare patients. 35% may be forced to limit care to Medicaid or charity care patients. And those that are hospital employed expect their contracts to be renegotiated to reflect lower reimbursement. While some hospitals and health systems will be able to mitigate the overall impact of reimbursement cuts because they also employ physicians who are scheduled to see payment increases, many hospitals will have to make difficult choices. Some of these reimbursement issues will certainly be applied to Medicaid as well as other payers, and the congenital heart surgery practice will inevitably be affected. Reimbursement currently tops the list of critical issues for cardiothoracic surgery, but there is a growing list of issues that would also benefit from increased CHSS advocacy efforts. NIH and CDC research cuts that impact congenital heart disease and lifelong surveillance programs, greater funding for smoking cessation for parents of children with congenital heart disease, insurance coverage to ensure access to health care and mental health and support issues for both patients and parents of children with congenital heart disease, and the list goes on. In today's world of escalating medical care costs, healthcare systems are besieged and funding resources are stretched, so it is essential that we advocate on behalf of our specialty and on behalf of our patients, both the children and their families. As we consider the challenges in front of us, working in a complex healthcare system, getting it right when it comes to quality, public reporting, regionalized care, the high cost of care, and the growing importance and relevance of advocacy, it is easy to be overwhelmed and say, let's just let someone else deal with this. These are our challenges, our responsibilities, and our opportunities. So what makes an organization's contributions so special and so impactful? What is it about CHSS that makes us the right ones to lead on these issues? Congenital heart surgeons are doers. We're problem solvers. We're collaborators. We're risk takers. We're innovators. And we get things done. CHSS is a patient-centric and member-centric organization. Our opportunities today are different than our predecessors yesterday. Let's be bold and continue the CHSS legacy by making all aspects of congenital heart surgery even better for our patients and members moving forward. This is our time, and to me, this is purposeful legacy building. I'd like to close with my favorite poem written almost 100 years ago by Miss Will Allen Dromgoole, titled The Bridge Builder. Imagine you, as a CHSS member, to be the old man in the poem, and the fellow pilgrim or pilgrims to be our patients. An old man going a lone highway came at the evening cold and gray to a chasm vast and deep and wide, through which was flowing a swollen tide. The old man crossed in the twilight dim. The rapids held no fears for him. But he turned when safe on the other side and built a bridge to span the tide. "Old man," cried a fellow pilgrim near, "you're wasting your time in building here. Your journey will end with the closing day. You never again will pass this way. You have crossed the chasm deep and wide. Why build you this bridge at even tide? The builder lifted old Gray his head. Good friend, in the path I have come, he said. There follows after me today a youth whose feet must pass this way. This stream, which has been a naught to me, to that fair youth may a pitfall be. He too must cross in the twilight dim. Good friend, I am building this bridge for him. Gratitude is in order. I would like to thank and acknowledge and congratulate Dr. Saris, the president of the European Congenital Heart Surgeons Association. I have appreciated our collaboration and look forward to more opportunities for CHSS and EXA to work together. The CHSS administrative team has been awesome, conscientious, organized, and always providing great suggestions and unwavering support to the Executive Committee and the CHSS membership. A sincere thank you also to my colleagues on the CHSS Executive Committee and to my many colleagues and friends in the CHS membership. I have had many mentors and role models throughout my life, some inspirational and motivating, some have taught me the craft of surgery, some have taught me basic science research, and some have taught me clinical research. And some have provided support and guidance to me throughout my career. A special thank you to Dr. Marshall Jacobs, who has been a much appreciated confidant and sounding board for me in my leadership roles. Marshall, your energy and enthusiasm for the CHSS and our specialty is awe-inspiring. A sincere thank you to my operating team at Mayo Clinic and my longtime secretary, Rhonda Brinks, and nurse practitioner, Lucinda Strutz. I've been blessed with an incredible family. My parents were my greatest inspiration growing up. The loving and encouraging support of my 8 incredible sisters has also been motivating and inspiring. And finally, to my family, 3 amazing children. Michael, a financial analyst at Wells Fargo in Chicago. Grace, who is in commercial design and architecture in Denver. And Patrick, who is a senior at the University of Minnesota, also studying business and finance. And finally, to Anne, my amazing wife and soulmate for 28 years and devoted mother of our children. I love you more than you know. Thank you sincerely for your endless support, love, and understanding over the years. It has been my highest honor and privilege to serve this great society that has already had tremendous impact. CHSS is the face of congenital heart surgery, and our opportunities are enormous, and they are hard. However, when things get hard, our performance gets better. CHSS is our platform to make this specialty better for our patients tomorrow. Let's do it.
Well, Joe, thank you so much for such an insightful, comprehensive, and inspiring presidential address. I would like to express on behalf of our entire membership our admiration and gratitude for your amazing leadership and example during these particularly challenging times for us as members and for our specialty as a whole. I cannot think of a stronger leader to guide simultaneously CHSS and STS through this unique time in our personal and professional lives. You're really a role model for all of us.